Hello, good morning, good afternoon, good evening. A very warm welcome to Meet Menaca talk show. Today, we are going to be discussing prostate and urological health in our episode 124 with Professor Prasanna Suryakumaran. Really feel privileged and honored to have him here. I know he is a busy individual. So firstly, thank you so much, Prasanna, for joining us.
Thank you so much, Menaca, for the invitation. Grateful to be here. Thank you.
You're very welcome. Why was this talk show born? Our mission is to touch and inspire 1 million hearts and lives to improve health, happiness, and hope across the borders. We feature experts in their respective fields, like today, and we also host real stories to create a positive social change, particularly about topics what we must speak, but we usually shy away from speaking. It's a vibrant 90-minute multicultural online talk show to celebrate each and every one of you. We would be delighted to have you join our shows, which live stream airing the first Sunday of every month in UK time, 2 o'clock. Today, this is a really important topic. Why? Answer is going to be discussed and I think enlightened by Professor Suryakumar. So I don't want to talk about a subject which I am not very well versed with. Let me tell you why we have asked Professor to come and speak about this, because he's a professor of urology in Cleveland Clinic, Lerner College of Medicine. He's a visiting professor of urology and member of the Faculty of Clinical Medicine and member of Congregation, University of Oxford. He's also a visiting professor of urology and robotic surgery, All India Institute of Medical Sciences, consultant urological and robotic surgeon, University College London Hospital and Cleveland Clinic London, clinical lead for urological innovation, Avagen Health, lead for consultant interview coaching and urology, High Yield UK, chief men's health officer, Smart About Health, and medical advisor to Candesic and Alira Health. As you can see, we couldn't get anyone better to talk about this topic. So today we are going to discuss prostate and urological health with Professor Prasanna Suryakumaran. And welcome on board, everyone. Thank you so much for supporting us as well all this time. Another year is going to come to a close, and I think it is a good way to almost finish it, because this topic we have been thinking of to talk about, we at last got the right person to give some insight about this. Without further ado, let's get into the topic. Professor Suryakumar, of course, you have a very in-depth and wide knowledge. Let's try to make it and break it down into small, digestible information for people. So to begin with, what is the prostate?
Okay, so that's an easy one for 10, I suppose. So the prostate is an organ that lies at the neck of the bladder. So in a man, so of course you have the penis, and through the penis you have the urethra, which is the hole you pee through, and that connects to the bladder. And then of course you've got the ureters, the water tubes that connect up to the kidneys. Urine gets filtered from the kidneys, go down the ureters into the bladder fills up, and then when you have the urgency to wee, the bladder contracts, and it all goes through the urethra. But at the neck of the bladder, so at the top of the urethra, neck of the bladder, you have this organ that's like a donut shape. It's called the prostate. So it's a donut shape. There's a hole through the middle of it for the urethra to go through. And so the prostate lies there. The purpose of the prostate is it secretes certain fluids that are helpful in fertilization of a woman's egg. So it has some mild fertility role, which of course is not so important as you get older, but is important in younger men. And so that is what the prostate is. But the main problem with the prostate is that as you get older, it starts to develop disease. And it's of course not of any much use for men in the later years for fertility. So it starts to be more of a problem than a help.
Okay, thank you so much. I think at least everyone can understand where it is and what it does, because I think it is another taboo subject. I mean, you will be knowing better than me, because as my limited knowledge goes, not many people go and seek help regarding this problem, and it's left too late often.
Yes, and part of the problem for that is that some of the, or one of the biggest problems of the prostate is that it can develop cancer within it. And so you get prostate cancer. It's actually the commonest cancer in men in the Western world, outside of skin cancers, common solid cancer in men in the Western world. And often the cancer doesn't have symptoms until it's too late. So you have to be quite proactive, and generally men are less proactive about their health than women anyway. And then, of course, when it comes to the prostate health and down below, and problems with sexual function, problems with urination and stuff, as you say, it's a bit of a taboo subject. They're less likely to talk about it. And then they're not likely to screen for things like cancer because they're asymptomatic. So there's a whole number of reasons why prostate problems present later on, and why they therefore become less well treated. But because they're so common, especially in the older man, it's very important that we discuss it.
Thank you so much. You mentioned cancer, but other than that, or including that, what diseases does the prostate cause? In younger men, to begin with, and then we can go into older men.
Yeah, absolutely. So we'll start with younger men and go our way forward. Now, remember, the prostate develops as a result of the main hormone testosterone. So, of course, at birth, the prostate is barely there, and it starts to develop. So, in childhood, there's really no prostate problems. But as you get into younger adulthood, you can get inflammation of the prostate. Because if you remember from what I said about the anatomy of where the prostate is, when you sit down, you're sitting effectively as a man on your prostate. And so the prostate is often subject to repeated trauma. If you cycle, if you sit for prolonged periods of time, that can all cause inflammation of the prostate. And that's a condition called prostatitis, which is actually the commonest reason people come and see me in my private clinics at Cleveland, is younger men who have prostatitis. It's very common. And that is a kind of temporary inflammation of the prostate, not cancer, but can cause waterwork symptoms, can cause pain, can cause problems with sexual function, those sorts of things. So prostatitis is a very common thing in younger men, easily treated with tablets generally. Sometimes you need to do more invasive things like prostate massages. You may need to do pelvic floor muscle exercises or physiotherapy to help strengthen the support structures to the prostate so that the prostate doesn't get inflamed as much. And you may even need to give help for men who are suffering from erection problems, because the erection nerves go along the side of the prostate. So if the prostate is inflamed in any way, it can then affect the nerves that supply erections and can cause problems with the erection. So there are a number of things that can be done, but it's a very treatable condition. And the good thing is that there's no association between inflammation of the prostate in the younger man and cancer or enlargement of the prostate as the man gets older. So it tends to be a defined condition that young men suffer from. Other risk factors for that will be things like stress. So typically it's in men who have got stressful jobs, sitting for prolonged periods of time. They drink a lot of caffeine. Caffeine, I know I'm speaking to a Sri Lankan audience, so they probably drink a lot of tea, but caffeine in the form of tea and coffee is very bad. Generally, it causes inflammation. Acidic things can cause inflammation. The other thing that can cause inflammation, which again might be relevant to a Sri Lankan audience, is spicy food. So the capsaicin is a chemical found in chili that translocates from the gut into the bladder and can cause inflammation of the bladder as well, so, and the prostate. And so you can get urinary symptoms as a result of spicy food. So stress, caffeine, spicy food, prolonged sitting, those are the sorts of things. Direct trauma to the prostate, e.g. cycling, bumping your prostate up and down on a saddle as you're cycling. All of those things can cause inflammation of the prostate in a younger man. So those are the sorts of things that we would look out for in the younger man. The treatments, of course, as I say, would be start with conservative things to try and improve the lifestyle, decrease caffeine, stress. Don't sit for prolonged periods of time. So use a standing desk if you're a young worker. Those are the sorts of things we would do. And then if that fails, we talk about medications that can relax the muscle of the prostate. We talk about medications that can reduce the inflammation of the prostate, medications that can help with the erections. And then if those things don't work, we talk about pelvic floor exercise to strengthen the support of the prostate. And we also will do things such as a massage to try and get inflammatory cells within the prostate. So there's a variety of fairly not particularly invasive, not particularly side effect causing things that can be done fairly simply to help younger men that have got inflamed prostates. Sorry, you want to ask me about
Thank
that?
you. And I just wanted to ask, like, when you say young, because what is young is very subjective and it keeps changing every
Yeah.
a few years. So
What is young?
what do you bracket? What kind of bracket would you say?
What is young is my age and below, right? So to anybody, so if you're older than me, you're old. If you're my age or below, you're young. So, but really, it's about 40. So if you're in your 20s and your 30s, typically that tends to be men that can, but it's generally not in men in their 60s and 70s. We're much higher risk of enlargement from benign growth, what we call BPH, benign prostate hypertrophy or hyperplasia, or prostate cancer, sadly. So younger men, prostatitis, older men, prostate cancer and enlargement from benign disease, BPH.
Sure. Thank you so
And
much.
40 to 50 is sort of cut off for that. Yeah.
Other than prostate cancer, what does the older men have to? What kind of problems do they have?
They get benign enlargement of the prostate, what's called BPH.
Sure.
So that's a benign enlargement of the prostate. And one of the big problems actually is it can be sometimes quite difficult to differentiate between benign enlargement of the prostate and a cancerous growth within the prostate. And so that's where a lot of the confusion lies between those conditions.
Sure. Thank you so much. You mentioned prostatitis, particularly in young men. How can you manage that? And do they have to know anything in particular? What can they do about it?
Yeah, so as I said before, it's you start off with kind of, like all doctors, I believe that you should start with conservative things first and then move on to more invasive things, because anything the doctor does to you that's invasive has potential side effects. And so you need to make sure that the cure or the treatment is not worse than the condition. So we always start with conservative things that people can do. So that'll be, as I say, and so I take a history to look at what the risk factors for why they've developed prostatitis. As I say, it's typically stress. It's typically prolonged sitting. They tend to have jobs where they're sitting down all the time. So I just talk to them about, can they get a standing desk, how to build in standing within their routine, to change their chair, to put in, to use a cushion or a pillow to sit on. For the cyclists, I talk about maybe having prostate friendly saddles, which you can get in bike shops, or even I think on Amazon, that will help relieve the pressure of the saddle on the prostate. We talk about reduction of caffeine, or at least if they need to have caffeine, because it seems like lots of people need to have caffeine just to get through their day. But if they do need to have caffeine, then they should always dilute it with water. So, if I was to pour hydrochloric acid onto your skin, it would burn. But if I dilute that hydrochloric acid a million parts with water, then it won't burn anymore. So in the same way, the caffeine might burn your bladder and your prostate, but if you have a whole bunch of water with it, then it will have less of an impact. So we talk about strategies to do with caffeine reduction or dilution, stress reduction, as I say, affecting how they sit, or the amount of time they sit, stress, and chili in terms of spicy food. And then we can talk about medications. So there are specific medications that are called alpha blockers that help relax the muscle of the prostate. Because typically what happens when your prostate is inflamed, it goes from being like one of those stress balls that people use that's nice and squidgy, to kind of like a hard apple. And so actually what you need to do is to get the give back in the prostate so that the water can flow through the middle of the prostate, because there's a hole through the middle of it. And so what you can do is give some tablets that relax the muscle of the prostate. They don't actually change the size of the prostate, but they relax the muscle of the prostate and help that way. And those are things like what are called alpha blockers, things like tamsulosin, alfuzosin, doxazosin, etc. And then there are other tablets that work directly on the prostate to reduce the inflammation. So rather than just about trying to change the give of the prostate, actually try and deal with the process of inflammation by reducing it. And those are typically antibiotic type tablets like afloxacin, the fluoroquinolone antibiotic class. And then there are also tablets that help with improving the blood supply to the prostate, because again, when the prostate is inflamed, you don't get such a good blood supply to it. That affects the erectile function. And so we talk about tablets that increase blood supply to the prostate, which are the same things that people use for erections, but at a much lower dose typically. so the kind of Vigras and the silences, those PD5 inhibitors. And then if those things don't work, we have to go to more invasive things like massages of the prostate, looking inside the bladder with a cystoscopy to make sure there's no underlying cause that's more sinister for the inflammation. There's no cancers in the bladder or the prostate, etc., that are causing the inflammation. But those things are not common, but they need to be excluded if patients don't respond to simple things. And then we also talk about how to strengthen the support structures of the prostate, just to help stopping it getting so, inflamed in future. Things like pelvic floor exercises, the same exercises that women who give birth to children would typically do to strengthen their pelvic floor. Men would do those same sorts of exercises to help stabilize the muscle of the prostate. So those are the sorts of management options for prostatitis.
Thank you so much for that. I mean, I knew, and you mentioned as well, one of the common cancers for men, particularly after a particular age, is prostate cancer. So what is the best way of checking for prostate cancer, knowing that it gets missed till late very often?
Yeah, so the best way of checking for prostate cancer is to undergo some form of what we call screening. So it's not to wait till you get symptoms, because the symptoms, and this is why I have to talk about prostate cancer and benign enlargement at the same time, because the symptoms of an enlarged prostate are, as many older men would know, because as I say, when the prostate gets enlarged, it doesn't just get enlarged on the outside, it also gets enlarged on the inside. And if you remember at the beginning, I said that there's a hole through the middle where the urethra is that you pee through like a donut. And as the prostate gets enlarged, what will happen is that hole will get smaller and smaller and smaller, because the prostate is getting enlarged on the inside as well as the outside. And so you have to pee through a smaller and smaller hole. And so if you remember Poiseuille's law from whatever your O-level time was, you'll know that the smaller the diameter of the tube, the higher the pressure has to go up by 4 times as the hole halves in order to generate the same flow. Okay, and so in order for that, you need to have a much stronger bladder. Of course, the bladder is a muscle, and as you get older, like any muscle in life, it gets weaker. So you take a the average 70-year-old man, his bladder will be weaker than it was when he was 50 or 40 or 30. His prostate will be enlarged, so his hole he has to pee through is smaller, so he can't generate the same force and pressure to push through, and therefore he gets waterworks symptoms. He'll start, therefore, instead of having a strong flow, he'll have a weak flow. He'll start having to therefore wake up at night because he can't empty the bladder properly, because the prostate is acting as an obstruction. He'll go frequently during the day. He may get a sense of urgency for him to rush to the toilet. He may stop and start when he pees. He may dribble towards the end. He may have a feeling of never finishing properly, and he may start developing urine infections because the bladder is not emptying properly, and there's this stagnant urine left in the bladder, which acts as a focus for infection. So you start getting all of these symptoms as you get older, and you've got the symptoms of a benign enlarged prostate. But you may also have prostate cancer. But the prostate cancer is not, and this is really important, the prostate cancer is not due to the symptoms, or is not causing the symptoms, I should say. The symptoms are caused by the benign enlargement, which happens to every man's prostate as they get older. Just as we get older, our hair gets grayer, our hair starts to fall out, we start developing wrinkles. It's a normal aging process that as a man gets older, their prostate gets larger. And then you start to get symptoms due to that prostate enlargement. Prostate cancer, when it's confined to the prostate and therefore at an early stage, has no symptoms. So it doesn't mean that you won't have those waterwork symptoms I've just described. It just means that the cancer isn't what's causing those waterwork symptoms. Those waterwork symptoms are happening because your prostate is enlarging. The cancer itself has no symptoms. And the reason for that is because prostate cancer typically occurs on the outside of the prostate. And as I say, what causes the symptoms are enlargement growth on the inside of the prostate, making that hole that you pee through smaller. So prostate cancer is on the outside, it's not symptomatic, and then it typically spreads outside the prostate into the lymph nodes, into the bones, at which point it's effectively a death sentence. So you need to diagnose prostate cancer way before you look for symptoms, because the symptoms won't relate to the cancer unless it's already spread. And so the only way of picking out prostate cancer in a man at a point where it's curable is by going looking for it. So not waiting for waterwork symptoms, not waiting for any other symptoms. And so the only way to go looking for it, if you haven't got symptoms, is to do a couple of tests. One is called a PSA, which is a blood test for the prostate. As I say, it's not a blood test specifically for prostate cancer. There is no specific blood test for prostate cancer. PSA stands for prostate specific antigen. So it is a prostate specific blood test, which means that any condition that affects the prostate will cause the PSA to go up. So if you've got prostatitis in a younger man, the PSA can go up. If you have a benign enlargement of the prostate, the PSA can go up. If you have prostate cancer, the PSA can go up. So it is very difficult as a layperson to know if your PSA is raised because of infection, because of benign enlargement, or because of cancer. So then the other thing that usually will happen is that you can have an examination of the prostate to see if there's any, which is a finger up the back passage, to see if there's anything that feels suspicious. Because even if the prostate is enlarged from benign growth, the way it feels typically is different to the way a cancerous prostate feels. So a benign prostate will typically feel, I guess, like the tip of your nose. It can feel a bit firm. So normal prostate, I guess, will feel like a lips, feels nice and soft, smooth. A benignly enlarged prostate will feel like the tip of your nose, feel a bit firmer, but no lumps or bumps, particularly firm but not hard. Whereas a cancerous prostate will typically feel hard, and therefore you can sometimes make that likely diagnosis with your finger in conjunction with the PSA. But then the other thing that's very important then is to go ahead and have a diagnostic MRI scan, which is a non-invasive scan. You lie on a bed, as it were, and there's a kind of donut machine that you go through, and it takes an MRI. There's nothing invasive about that, except you often need to have a needle put into the hand to inject some contrast, which gives better pictures of the prostate. So you have what's called a multi-parametric MRI scan of the prostate, and that, along with the rectal exam and the PSA and the other risk factors that the urologist will ask about, things like family history, ethnicity, age, all those things will be taken into account to determine what is your risk then of having significant prostate cancer. And then based on that, you may be offered a biopsy. And then based on that, if you have a diagnosis of cancer, they'll talk about treatment. So the key, I think, and you talked about 5 key messages before to me. I think one of the key messages I want people to take away, especially if they are above the age of 60 as a man, is that they should go looking for prostate cancer rather than waiting for it to look for them. And so by that, what I mean is they should have a PSA test. They should consider having an examination by a doctor. And if there's any doubt, they should have an MRI scan. And then just to focus on the high risk groups for prostate cancer. The average age of diagnosis of prostate cancer in this country is about 67. So it's sort of mid to late 60s onwards, but I have seen men as young as their late 30s with prostate cancer. But typically it'll start really after the sort of 50, 55 age, and then it becomes very common. And so as you get older, you should think about it. If you've got a family history of prostate cancer, that's a big risk factor. So for example, if my father had prostate cancer, then my risk would be double, okay? So if my brother had prostate cancer, I don't have a brother, but if I did and he had prostate cancer, my risk would be double. So a first degree relative with prostate cancer will double your risk of prostate cancer. A second degree relative will increase it by 50%. So that would be your uncles, those sorts of things. And then also there's a slightly increased risk if you have what's called a BRCA association, which are a group of genes that prostate cancer is associated with, but also with breast cancer and ovarian cancer. So if you have female relatives as a man who've had either ovarian cancer or breast cancer, that also slightly increases your risk of prostate cancer as well. So those are the kind of family history things. And then the other thing is ethnicity. And one of the good things about being Sri Lankan is you're in a low ethnicity group. Sadly, we're in the high risk groups for hypertension and for diabetes and for heart disease and for high cholesterol and for all sorts of other things. But for prostate cancer, we're in a lower risk ethnicity group. The highest risk ethnicity groups are the Black men, Eskimos, Ashkenazi Jewish people, but Jewish men, but luckily Asian men are at lower risk. Having said that, there's a huge exponential rise of prostate cancer among Asians because they're no longer dying, which is a good thing. They're no longer dying in their 50s and 60s, typically of heart disease and all these other things, diabetes, etc. So they're living long enough, and they've also sadly adopted Western diets in this country, especially. And the diet is another risk factor for developing prostate cancer. Diet high in sort of fat content, especially animal fat content, is a risk factor for prostate cancer. So the typical Western diet increases the risk of prostate cancer. So Asian men in this country have a higher risk of having prostate cancer than Asian men in Asia. And there was a large study actually done among Japanese men who moved from Japan to California and showed that they started to develop prostate cancer risks much more close to white Caucasian Californians than they did to their indigenous Japanese people back in Japan. So there is a high risk among our population, perhaps, than there would be if we were still in Sri Lanka, but it's still lower than white men and black men in this country. So those are kind of risk factors, things to look out for. As I say, check your PSA as you get older, and don't just check it once. That's the other thing, Menaca, I think that's very important to say. You know, people come to my clinic all the time and I ask them what their PSA is, and they say, oh, it's normal. I said, what does that mean? What does it mean to say that your PSA is normal? It's like saying your height is normal. You're 5'10", your height is normal. My father is 5'7", I think. His height is normal. I'm 6'2", that height is normal. But if I was 5'7" yesterday and today I'm 6'2" and tomorrow I'm 6'5", they may all be normal heights, but there's a problem there, right? So the same is true for the PSA. There's no such thing as a normal result. What matters is how it changes. If it's stable, and low, that's great. But if it's 5'7" equivalent and then 6'2" a year later, there's a problem. So as it changes, you need to think, okay, even if it's changed for being within normal, it's changed significantly, and that might be abnormal. And the reason for that is because prostate cancer typically will cause a quicker rate of rise of PSA than benign disease. And so as you get, if the PSA starts to climb up quickly, that's more worrisome than if the PSA is fairly stable. And that's not, that's irrespective of what the actual number is. So monitoring your PSA and checking that it's stable over a period of time is very important. If it's not, then that would warrant an examination and, or as I say, an MRI.
Thank you so much. I think the last one was very important, isn't it? Because most of us, for many things, we just go check it once and forget about it and think we're okay, we don't have to do. And plus, I think important example is what is in relative terms where you are rather than what should be. I think that is also as important for people to know, particularly in our communities. Like we ask for different people and we think, oh, okay, fine, mine is low or higher or whatever. But I think it's better for you to go and check. Listening to you, person, I was thinking for women, we have mammograms to go for screening. So do men get invited for PSAs and MRI or not really, or they have to be more proactive and go and ask for it?
Sadly, they have to be more proactive in this country. So in the United States, I did some of my prostate cancer training in the United States in New York, and I also did some of it in Stockholm in Sweden. And in both Sweden and in the United States, there are prostate cancer screening programs, and men are invited. And actually, if you take the United States, the percentage of men that typically present with advanced prostate cancer, metastatic disease, where it's no longer curable, is 8%, compared to sort of 92% where it's confined. In the UK, those numbers are more like 25% to 75%. And the reason that there's much more, therefore, delayed diagnosis in the UK and men presenting with incurable disease is because we don't screen for prostate cancer with PSA in this country. And the reason we don't do that is because there's all of this controversy around PSA because it goes up for a variety of different things, as I've just mentioned. So it's not as simple as, you know, a test like a mammogram for breast cancer where it says if there's a risk or not. You have to interpret the PSA in light of the age of the patient, the ethnicity of the patient, the waterwork symptoms, the size of the prostate, because a lot of it may be driven by benign disease, whether there's any inflammation in the prostate, etc. So it's a very complex test to interpret, and therefore there will be a lot of false positives positives and a lot of false negatives, and therefore the government position is it's not cost effective, and therefore we don't do it, which I think makes sense on a kind of mass screening level. But clearly, if you're an Afro-Caribbean man, whose father died of prostate cancer at the age of 50, then you need to have your PSA checked when you get to 40, 45. That's a no-brainer, because your risk of having significant prostate cancer in your lifetime will be 50%. If, on the other hand, you're an Asian man whose father never had prostate cancer, has got no family history of prostate cancer, and you've not got any other risk factors at all, then you might want to just check it once and then check it maybe a couple of years later, check that it's stable and not get too concerned about it. So I think it's all about smart screening. I wrote papers on this. So rather than doing the same thing for everybody, we want an individualized, kind of personalized approach to your risk. And, for the men on the call, I don't know what their individual risks are, but everybody's will be slightly different. So that's where I think going to speak to an expert or someone that actually understands a bit more than just do a PSA or don't do a PSA is important. So, yeah, I think, sadly in this country, we don't offer routine screening to most men. So there are some, private medical insurance companies who, as part of their package, will offer a PSA to some men who are insured, and that's great. But as I say, the important thing is, even if it's normal, don't ignore it, get another one checked. And also it's important to remember, I think, Menaca, that prostate cancer can develop at any time. So even if you don't have it at 65, doesn't mean you won't have it at 66. When you don't have it at 66, doesn't mean you won't have it at 67, and so on. So even this week, I saw a patient who for 20 years, because his Ashkenazi Jewish, his father had prostate cancer when he was, I think, in his mid-50s, has been keeping an eye on his PSA and doing regular MRIs. They've been completely normal. And then this time around, his PSA is high and his MRI is abnormal. I've got to biopsy him in a couple of weeks. So he was shocked because, well, it's always been normal. I'm like, yeah, but you can develop cancer at any point. So just because it's been normal in the past doesn't mean it will always stay normal. And so, you've got to keep an eye on it. And that is true not just for prostate cancer, but for all health issues. Just because my cholesterol is normal today, it's not. But if it was, it doesn't mean it will be normal tomorrow or next year. I have to keep an eye on it, right? I have to always be vigilant about my health. So it is the same with regards to the PSA. I think the key thing, we talked about the mammogram for women, the key thing is that the equivalent for a man is the MRI. And having a good quality MRI that can be reported on by an expert radiologist in conjunction with an expert specialist urologist in prostate cancer is very important, because then you can look at the pictures, put it all together with the clinical history, the PSA, what it felt like on exam, what the age of the patient is, the family history, all these things together, and get a sense of whether or not this is a man that needs to have a biopsy or not. Because a prostate biopsy is a pretty unpleasant test. So we don't want to be, offering that to men willy-nilly. It also can have side effects and things. So, and that is the diagnostic test. Everything else is just about leading up to that diagnostic test. But the actual diagnosis of prostate cancer has to be made with a biopsy. And so we want to be very clear as to who we want to biopsy and who we don't want to biopsy. And that decision really is not something that the average general practitioner can make.
Thank you so much, Vishnu, because I think it's really important. A lot of confusion, and people, it's not so much more talked about, particularly in the South Asian community. And I think it's important for someone to know at least the basics to go through and get. But preventing is better than cure anyway. And as you mentioned, person-centered care or person-centered care management is so important in any part of healthcare. Including this. So thank you so much for that.
Cool, no problem.
Prostate cancer, unfortunately, some do get diagnosed, and it was interesting to see that you mentioning, even if you're a South Asian man who is living in the West, I know many of the callers, our audience today, are in the West. If they are diagnosed, how can they be managed? Like, how is prostate cancer managed? And more importantly, because there first is the big C word and the panic, and we go numb. So how does it get managed, and what people should know?
Yeah. So if they're diagnosed with prostate cancer, it depends on how much cancer there is, where the cancer has got to, and how aggressive the cancer is down the microscope. So there's three main things. So you do a biopsy. The biopsy tells you, okay, you've got cancer, but not all prostate cancer is the same. The reason I can spend my career dealing with pretty much one disease is because there's so much variety of prostate cancer. It can go from being like a household pussycat and a completely benign type cancer, all the way to being an aggressive Bengal tiger that will kill a man within a few months. And there's everything between those two spectrum, those two ends of the spectrum. And so it's important to know how much or where you are on that spectrum. And that is determined based on how much cancer there is, like the volume of cancer, where the cancer is spread to. If it is spread to, is it confined to the prostate, what we call localized cancer, or is it spread outside to the lymph nodes, or worse still to the bones and other places, what we call metastatic or advanced prostate cancer, because the treatment options are different. For the localized one is chance of cure. For the distant metastatic one, there really isn't a chance of cure so much as longer term control. And then the other thing to know is how aggressive the cancer is. So even if it's contained within the prostate and localized, what is its potential for spread? So if it's a more aggressive cancer, does it look like a Bengal tiger down the microscope, or does it look like a household pussycat, or does it look like something in the middle? That will help you determine what your risk of disease progression is, and your need for treatment, or need for quicker treatment, and your prognosis from that treatment. So that's what we call the grade of the cancer, how aggressive it is, the stage of the cancer, where it's got to, and then the volume of the cancer is how much cancer there is. So once you know those things, you can then develop a treatment plan. And remember, this tends to be a cancer that affects older men. So you then need to also understand, you also have to treat the man holistically. Because if you have an 85-year-old man who's had 3 heart attacks and 2 strokes, who's going to die of heart disease next year, who's got low risk prostate cancer, a small amount of cancer that's confined to prostate, that looks like a household pussycat, clearly that doesn't need treatment. If, on the other hand, you have a Bengal tiger type cancer that's confined to the prostate, but it's got a lot of it in the prostate, in a 50-year-old fit man, clearly that needs treatment. And then, of course, most of us are not at those extremes, they're in the middle. So that's why it's very important that you understand what the man's, what I call competing causes of mortality are. So what is his risk of dying if he didn't have this cancer from other things, heart disease, diabetes, strokes, blah, blah, blah. So those are the sorts of things that you need to put into the equation, as well as what their cancer is, and then try and figure out whether for this man, this cancer needs treatment. For most men who are relatively fit in their 60s and 70s, you'd hope they'd have a 10+ year life expectancy. And therefore, if they have anything that isn't just a kind of benign looking household pussycat cancer, what we call the Gleason 7 cancers and above, they would generally warrant treatment if it's confined to the prostate. And those treatment options would be either surgery, removal of the prostate, which is what I specialize in, or radiotherapy to the prostate, which is typically given with hormone treatment. Because as I mentioned earlier, the prostate growth, and this is also true for prostate cancer growth, is determined by the male hormone testosterone. So you can give certain blockers, hormone blockers that will deprive the body of the testosterone, and that will help control the cancer. Also makes radiotherapy more successful. So you can give radiotherapy with hormones for some men who perhaps are not fit for the operation, because you have to be fairly fit to have a major cancer operation to have the surgery. So surgery or hormones and radiotherapy, sometimes just the hormones alone. And if it's the more advanced cases where the cancer is spread, typically you would have things such as chemotherapies, hormone therapies, things like that, rather than surgery. Although I am actually doing or trying to run a trial to see whether surgery is helpful even in that setting. I ran the world's first and largest randomized trial in a kind of feasibility trial of that, and I'm now just applied for a near £3 million grant from the government to try and do that as a multi-institutional study throughout the UK, to look at the impact of surgery in men who've got more advanced disease. But the standard of care still, if they've got more advanced disease, they wouldn't have surgery or radiotherapy. They would just have chemotherapy and hormones and try to control the disease as best as possible. And if it's confined to the prostate, they'd have either surgery or radiotherapy with hormones to try and cure the disease. And then I guess the other thing to say is that if they are going to have some kind of surgery to treat their cancer, which would be what we would normally do for men who are sort of 75-ish or younger, if they were fit. Then it's also about, the quality of the surgery. So it will be based upon whether they have access to robotic surgery, the skill set of the surgeon doing it, et cetera, how fit they are. So those sorts of things also then come into play in terms of how men do afterwards.
Thank you so much. I think so many important things, and good luck for the grant. Hopefully, I'm sure it will contribute a lot for many people. So, okay, thank you for trying that as well. It's slightly different from the cancer, but what are the treatments for an enlarged prostate? Because I think you did mention that is another common thing.
Yeah. So step one for an enlarged prostate is to exclude prostate cancer. Step two is to treat the enlarged prostate. So again, there are lifestyle things that can help. Okay, so the reason you get waterworks symptoms from enlarged prostate is partly because the enlarged prostate itself reduces the flow. But it's also partly because it puts back pressure onto the bladder, and the bladder then can't empty properly. And so you start getting an unstable bladder, which is trying to push harder and harder and harder to get the urine through the prostate. And so the bladder becomes hyperactive or unstable. And so there are different things depending on how bad those two sets of symptoms are. So one, we can think about symptoms that relieve the obstruction of the prostate, and the other, we can think about things that relieve the instability or the overactivity of the bladder. And so for the prostate itself, again, we can think about tablets that relax the muscle of the prostate to make it, although it doesn't change the size of it, increases the kind of give in the prostate to help you pee a bit better. So again, those same alpha blockers we talked about for the younger man with prostatitis can also be, again, used here. The other thing is that we can think about tablets that actually shrink the prostate by depriving it to some extent of its blood supply, and then the prostate gradually gets smaller with time. That's a more longer term strategy, but those are tablets, what we would call the 5-alpha reductase inhibitor tablets. So they're tablets like finasteride, dutasteride. Some younger men will use, or even older men with finasteride for hair loss, because it also works on that. So those are the sorts of tablets that men can use to help with their prostate symptoms. And then to stop the instability of the bladder, there are tablets that actually dampen down the contractions of the bladder to stop the bladder going crazy trying to push through this narrow hole. And those are tablets that are typically called anticholinergics, but there are some that are better than that, called M2 blockers. So things like Mirabegron or Betmega would be an example of that tablet. So there are various tablets that can be used for the prostatic obstruction and the impact it has on the bladder. There are also things, again, with lifestyle, because again, you want to therefore do your best to try and stop the symptoms getting bad. And so you don't want to be drinking 6 gallons of water or beer at night and then not expecting to wake up, because you will. You want to also reduce your caffeine intake, as I said. You want to have good fluid intake throughout the day, but not, as I say, in the evenings. You want to reduce your spicy food intake, because all these things will add extra pressure onto the bladder. So you try all those conservative things. You then try medications. Those things don't work. You then can core a hole through the middle of the prostate to make the hole bigger. So rather than having a donut with a tiny hole like this, you make it bigger. And so you take it back to what would have been like 20 years ago, with a nice big channel through the middle of the prostate. And those are operations that are typically things like a TURP, which stands for transurethral resection of the prostate, where you go in with a wire and you make a hole through the middle of the prostate. You can use a laser to do that nowadays. You can use a variety of different things. The other day, I used steam treatment that again made a hole through it. But you're basically using some form of energy to create a hole through the middle of the prostate, such that the man can pee a bit better. Again, those are the kind of later options. So as I said at the beginning, always start with the conservative things first, because they don't have side effects, the lifestyle change, then move on to medications, and then surgery is a kind of last resort step. Yeah.
Thank you so much. Another word we often don't hear very much is testicular cancer. How do you check for testicular cancer? What is it about?
Yeah, so testicular cancer is actually a very common cancer. It's the commonest cancer in men under the age of 40. I don't know how many men on this call you have under the age of 40. Just looking on the screen quickly, I'm guessing that most of them are over the age of 40. But they have, I'm sure most of them will have sons, or some of them will have sons that are under 40. But yeah, so the commonest cancer in men So outside of childhood, but before 40 is testicular cancer. So again, it's a very common cancer. And again, the issue with testicular cancer typically is that it's not symptomatic. So you won't get symptoms from testicular cancer until it's spread. So again, the only way of picking it up is by looking for it. And the way to look for it is that men need to learn how to examine their own testicles. So I think most women know how to examine their breasts and are taught through various national campaigns to do that on a regular basis as they get older. No man I know has ever been taught from a campaign to examine their testicles, which is a shame because they should be doing that regularly. And if they feel, the good thing though, is that testicular cancer is almost never on both sides simultaneously. So it will always be one normal testicle. And so even if you don't know what a normal testicle feels like, you can feel one testicle and feel the other testicle feels different to know that, okay, well, there's something wrong. And then you go and see someone like me who can examine it properly and tell you. So the way is to examine the testicles regularly. If you feel any lumps or bumps that don't feel the same on the other side, then you need to go and see a urologist. And the urologist, like me, will examine you properly, and then we'll do an ultrasound scan, which is a simple scan, no, not invasive, a kind of jelly on the belly type pregnancy scan, but of the testicles, to just check that if there's any masses. If there are any masses, then you have an operation to remove the testicle. And then based on that, you may or may not need further treatment. But testicular cancer is a huge success story in the whole of cancer treatment over the last couple of decades. You know, a few decades ago, it had a horrible prognosis, whereas now 95+% of men with testicular cancer at diagnosis live more than 5 years. So it is a huge success story because if you pick up testicular cancer early, it's almost always going to be curable. So yeah.
Thank you so much. I know there's at least one under 40, but like you said, but I'm sure they will have someone in the family who will be under 40 for them to know. Thank you so much.
And also that's where it most commonly occurs. It can occur a bit later as well. So you can get this testicular cancer, which is typically a lymphoma, and the peak for that is around the 60s, early 60s. So yeah, there are, but that's less common than the standard testicular cancers that you get in younger men.
Thank you. Another thing which people often miss, perhaps, what does blood in the urine mean? I think, like you said, women are taught so much more about a lot of these things for various reasons. But for men, what does it mean and what they should do if they see that?
Yeah, so blood in the urine affects, of course, both sexes, so both women and men. Blood in the urine is usually a problem if you can see the blood. Sometimes you get blood in the urine on a urine dipstick, and typically that is not such a big problem, but it can still be a problem. And so if you have blood in the urine on the dipstick test that your GP does, or that you can see when you wee yourself, then that needs to be investigated every single time. All right. So it can't be ignored and think, oh, that's just okay, it'll be all right. You can have a variety of things that can cause blood in the urine. So it can be anything from anywhere in the urinary tract, because of course the urine is passing from the kidney all the way down to the urethra on the way out. And so for both men and women, anything in the kidneys, anything in the ureters, anything in the bladders, anything in the urethra can cause blood in the urine. And for men, also the prostate is there as well. So any cancers of the urinary tract will cause blood in the urine. So kidney cancer, bladder cancer typically will cause blood in the urine. Stone disease, kidney stones in the ureters, stones in the bladder, etc., can cause blood in the urine. Inflammatory conditions, so there's specific inflammatory conditions that are more common in women, things of the bladder, things like interstitial cystitis can cause blood in the urine. Other inflammatory conditions as well can cause blood in the urine. In the bladder, prostatic inflammation can cause blood in the urine. So a variety of inflammatory conditions, as well as cancers and stones and things, can cause blood in the urine. So you therefore then need to investigate with scans. So typically you'll have an ultrasound scan or a CT scan, which looks nicely at the kidneys and the ureters. And to look at the bladder, unfortunately, the scans are not very good at looking at the bladder. The best way of looking at the bladder is to actually pass the telescope, what's called an endoscopy, pass the telescope up the water pipe and look directly at the bladder, which is done by someone like me, a urologist, in both men and women. So you do what's called a cystoscopy to look at the bladder, and that will just check that there's no cancers or inflammation or stones, etc. So those are all the things. If the blood in urine is only seen on the dipstick, the most common cause for that is caffeine is caffeine drinking. So because caffeine, as I say, causes inflammation to the bladder, that can cause a few little bits of blood in the urine, not enough for you to see with the naked eye, but enough to spot on a dipstick test. But even then, there's still a 1 to 2% chance of there being a significant cancer. So even those patients still require some examination. The key thing, and this is, I guess, point 2 for your audience, would be if your risk of having a significant cause cancer from blood and urine is much higher if you're a smoker. Okay, so bladder cancer, for example, is at least 5 times higher in smokers than non-smokers. So if you've got blood in the urine and you're a smoker, then you have to be very concerned. If you've got a bit of blood in the urine that you can't see just on dipstick, you're not a smoker, but you do drink a lot of tea or coffee, then it's likely just to be that. Still needs investigation, but you can be reassured that the investigations are likely to be normal. But if you're a smoker, then there's a much higher chance of you having a significant cancer. Bladder cancer is more common in men than in women, but still, of course, women can also get bladder cancer, kidney cancer as well. And so, blood in the urine in either sex is important to investigate with a urologist, not just with your GP.
Thank you so much. It was interesting to, even as a dentist, it's interesting to see smoking and the link to cancer. And nowadays, shisha and e-cigarettes pop up in every other patient who comes to see you. Often tell them, we don't smoke, we have e-cigarettes or shisha. What are your thoughts? I know it's not your expertise, but what would you say to that?
Yeah, I think there's not a lot of literature on the impact of vaping and things like that, e-cigarettes, on things like bladder cancer, kidney cancer, prostate cancer, etc. So I can't give you a kind of academic answer to that because we just don't have that data. Because remember, these things develop over many years, right? So that the craze that happens today or in the last 10 years will only potentially be able to have an impact in 20, 30, 40 years time. And so we just won't have that data for a while. But there is some data, as you know, that e-cigarettes and vaping still have harmful chemicals in them, some of which are carcinogenic. So yeah, I mean, of course, it's better than perhaps smoking cigarettes, but it's still better to not do either.
Thank you so much. Because even as a dentist, a lot more people now come in and say, oh, we do cigarettes or vaping or shishas has become so much more common than people coming and saying they smoke 20 cigarettes a day like before.
Yeah, absolutely.
Thank you so much. You have covered so much. And one of my mentors used to say, the test of the knowledge is if you can explain it like how you explain to a 5-year-old child and they can understand. And I didn't know anything about this subject. I didn't understand. I'm sure everyone will agree. So thank you so much. It shows your expertise in the field. A lot of people come and join and listen, and so many more will go and listen to it later from social media or YouTube channel. But people who missed, and if anyone wants to go to tell their children or colleagues or friends, what are the 5 things you think they must remember to go and share?
Okay, so I'm pretty much starting. I have to think of 5 things. Okay, so firstly, I guess if you're a younger man, examine your testicles often, regularly, and if you notice any lumps or bumps, check it compared to the other side. If there's any asymmetry, then you need to go and see a urologist, not just your GP. Okay, that's the other thing I would state is GPs are great. I'm not going to slag off GPs. They're great, but they know very little about specialist urological diseases, because most of us at medical school spend about 3 days doing urology. So they certainly are not capable of diagnosing cancers with their hands. So you need to get an examination by a urologist if you've got a lump in your scrotum that isn't there on the other side. Okay, so that's for the younger man. If you're the younger man and you've got waterwork symptoms, don't be stressed it's prostate cancer. Almost certainly is not, but it may be prostate inflammation. Think about reduction of your caffeine and going and seeing a urologist for further explanations and investigation. So that's what I'd say to younger men. To older men, I'd say if you are above the age of 50, 55, with or without a family history of prostate cancer, you should have a PSA test regularly to establish that it's stable and low. And if it is neither stable nor low, or low, I should say, then you need to go and see a urologist to discuss having a finger exam and potentially an MRI scan, followed maybe by a biopsy. Okay, so Do not wait for symptoms. I guess his point is part of that point. If you're an older man and you've got waterworks symptom, don't stress that it might be cancer. There may be cancer, but a urologist will look for that. But it's almost certainly going to be at least some element of a benign enlarged prostate. And for that, there are medications that are very successful, and also, if need be, surgery down the road if needed. So that's also very treatable. If you're getting up 3-4 times at night, you don't have to live with that. You can see a urologist who can sort that out. Okay, 3-4 times a night a week. So I think that's the point. That's take a message number 4, and take a message number 5 is, if you see blood in the urine, visible hematuria, we call it, that needs investigation by a urologist, not by a GP, but by a urologist, with things like scans of the upper urinary tract, the kidneys and the ureters, and then potentially cystoscopy of the urethra and the bladder. So, and that's the case if you're in both sexes, and especially if you smoke, your risk of having significant cancer in the urinary tract is much higher. So, point 6, I guess, for everybody, regardless of whether they are interested in prostate and urological health or whatever, is just don't smoke. It's really just bad for you on so many levels, including urology.
Thank you so much. It almost reminded me of a bonus point. Thank you. What are your thoughts about the show, and what has been your experience like?
Yeah, no, I mean, it's great, I think, to have the opportunity, Menaca. I mean, I think I spend a lot of time actually giving these sorts of things, and you get a lot of traction from quite well-educated Caucasian men generally, who are generally, in social class 1 and very proactive about their health. But actually, reaching out to some communities is more difficult, and I think for whatever reason, Asian people tend to be, I don't want to generalize, but they tend to be a bit less proactive about their health, let's say, and not so worried about, keeping themselves fit and healthy. And I think actually anything that, and I commend you for doing it, anything that people can do like you to increase awareness of conditions, that can affect them. As I say, prostate cancer is the commonest cancer in men in the Western world. Is, I think, really helpful and really important. So, it's really nice to have the opportunity, I think, to reach out to Asian men. And of course, it's also nice to have the opportunity to give back a bit, because I'm Sri Lankan and very proud to be Sri Lankan, although not very proud of the Sri Lankan cricket team recently. But apart from that, it's very good to be Sri Lankan and to be, and to therefore to help the Sri Lankan community and to reach out to them and to improve awareness of important topics like prostate cancer among the Sri Lankan community is great. So thank you for that.
Thank you so much. I know you're a very busy man. Shall I say, I waited for 6 months to get you on the show, and I'm so glad I managed to get you on the show. So thank you so much. Really honored to have you on the show.
I waited till November, really, because during the summer I like to take my kids for golf on a Sunday afternoon. So
I'm sure life happens. We all have other things, right? Other than profession, balanced life. Thank you so much. Now, by tradition, I'm just going to say next month is going to be more of a light-hearted networking kind of event for December, just before we finish the year off. I would lastly ask Prasanna, if somebody wants to get in touch with you, I know you are very active on LinkedIn, how people can catch you before I go to Nikki.
Yeah, no, I mean, I think LinkedIn is probably the best way. If they can join, they can just connect with me through LinkedIn, and then it's easy to LinkedIn message. That's probably the best way. I mean, I have a relatively high profile, so if you just type my name into Google, there's a whole bunch of things that come up, from UCLH, Cleveland Clinic, University of Oxford, British Association of Urological Surgeons, so all the kind of top hits, and all of them will have my contact details for those various different organizations. So they can easily, it's very easy to get hold of my email address. It's very easy to get hold of where I work. It's very easy to get hold of me directly through LinkedIn. So yeah, I'm happy.
Thank you so much. Thanks so much, Peter. And if anyone wants to have your Prasanna's LinkedIn profile link or something, please drop a text or email, and I'm happy to share that as well. I have it. Um, Thank you so much. Now over to Nikki Chandrana to give the vote of thanks.
Yeah, great. Thanks, Menaca. Wow, I'm not sure where to start. I must admit, because I wasn't sure what to expect coming into today's session. I myself personally don't work in the healthcare industry. I work in the financial services industry. So when Menaca asked me to join and provide the vote of thanks, I was slightly skeptical at first because I wasn't sure what to expect. But I must say, from listening in to you and the discussion that's been had, food for thought more than anything. I mean, some of the things that resonated with me that you mentioned around stress, coffee. I'm on my third cup of coffee already today. So, I mean, I should know already, but you've just reinforced that message. Chili, unlike many of you that Sri Lankan, we share a common trait in that I'm a Hindu and Indian, and I love my food and spicy food at that. But I'll probably think twice about what I'm going to have for dinner this evening. And then sitting for long periods. I mean, like many of you, especially coming out of COVID, very much bums on seats, working from home in front of Zoom. So definitely something to think about in terms of making sure you're more active than not. But having said all of that, I guess on behalf of the Meet Menaca team and the audience, I'd just like to take a few minutes to extend our heartfelt gratitude to you, our esteemed speaker, for enlightening us on the critical topic of prostate and urological health. Presentation, as I mentioned, has been very informative, inspiring, and shedding some light on a subject that often does go unaddressed. Your expertise and passion was very evident throughout the talk, and it makes it for an engaging and easy conversation to have, especially to those like me that possibly haven't had as much knowledge as maybe I should have about topics like this. And you very much showed and highlighted the importance of regular checkups, early detection, but also provided valuable insights into maintaining a healthy lifestyle for urology and well-being. And I'm sure that the knowledge that you've shared today will undoubtedly benefit the community, raising awareness about crucial aspects of men's health. And so it's a testament to you, really, and the commitment in terms of making a positive impact on lives. And as Menaca alluded, I echo, I hope you get the grant that you referred to earlier. Sounds like there's lots that can be done in this particular space. I guess just to end on a slightly different note, I'm going to end with a poem, if I can. I won't take all the credit. You've probably worked out where I've got the poem from, but I'm going to mention the poem, and then I'm sure you'll tell me that, Nikki, you've done a great job if it was your own words. So, to our speaker, Prasanna, wise and kind, for sharing knowledge of the urological kind, we thank you with heartfelt cheer for making vital health topics clear. Prostate and urological healthcare in your care, you've shown us how to be aware of screenings, habits, and early detection, guiding us in the right direction. Your words, like a beacon, a guiding light, have shone upon our health's true plight. For educating us, we're truly thrilled. With gratitude in our hearts, we're filled. Your wisdom, a gift, you're graciously shared. For this, our gratitude cannot be compared. In verses, we thank you, our words, a token to a speaker whose wisdom has awoken. So thank you, Prasanna, once again. We're truly blessed for teaching us to be at our health's best. In this journey to wellness, you've been our guide, and with heartfelt thanks, our gratitude can't hide. And then just finally, I'll definitely be giving my father and father-in-law a call after the session and just check in to make sure that they book an appointment with their GP to get their PSA levels checked, because I suspect, and I'm not insulting their intelligence, but I doubt they'll know very much about it. So, but I'll be sure to educate them and get them to book that early appointment next week. Thank you.
That's great. So it's been worth it, because at least I've helped two people, right? Your father and your father-in-law. That's great.
I'm sure more to come, more witnesses to come. Thank you so much, Nikki, for that lovely poetry. We won't ask you how you wrote it. Thank you so much for that. It's a very relevant, and I'm sure more than anything else, I put the screen in a different view just to say. Only today I realized how young Prasanna is when he said anybody younger, and then he mentioned their age. So congratulations for becoming a professor and contributing so much to so many people at that young age. So I hope everybody joins me in congratulating him before we go into the question time. With that, it's time to say goodbye. Stay safe, be happy, and keep smiling.